It is my pleasure to introduce our next speaker, Dr. Andy Nelson, Andrew Nelson, who is an associate professor in our department. He is board certified in both anatomy, pathology, and molecular as well, and he is a member of the Division of Molecular Pathology and Genomics, and he is Research and Development Director in the Molecular Diagnostic Laboratory. In the interest of time, because I can say many things about Andy, but you need to say. Exactly. But in the interest of time, I just want to mention something. With all the emphasis on papers and abstracts that you submit to national and international meetings on everything containing molecular aspects or molecular studies, you can easily see the benefit of making him a good friend.
Thank you, Melissa. All right, thanks everybody. So I'm going to go ahead and jump right in. It's always hard to follow Pari. You remind me of just how easy molecular pathology is after you talk about soft tissue and bone tumors. So I'm going to jump right into this talk. So I have no financial disclosures. The objectives of this, and this is really actually a morbidity and mortality talk that I've given before on a single case. But what I really want to do is focus on how disintegrated testing in the hospital system can lead to a confused and misdiagnosis, and really talk about, again, a theme that came up from the beginning of the morning about how important it is to have clear, integrated communication with our clinical colleagues and between ourselves within pathology. I do have a couple of considerations. I've blinded everybody, so Gio is gynecologic oncologist, SP is our surgical pathologist, and I would humbly submit that hindsight always has more clarity than foresight. I'll talk about disintegration, and that is something that's important, so I just wanted to put that definition up on this slide because, again, that is a lack of cohesion, a lack of stickiness between all of our work and tests that we put out into the Epic medical record. So this story starts with an Epic message that I got, and I'm lucky to be, on a relatively good, friendly basis with many of my clinicians and their nurse coordinators, et cetera. And so this nurse reached out to me and said, Dr. Gyne-Onc is supposed to reach out and talk about this patient. Her testing of her original tumor says she was POLE mutant. Now the outside testing has said that her recent lung biopsy says she does not have POLE. Well, that's interesting. And I got to admit that as a molecular pathologist, most of the time when I get these messages, it's bad news, and they think that there's a discordance between testing that was performed in-house and out-of-house. So that always gives me a little bit of an ulcer. And so the question is, why did I get this? Well, of course, I think one of the first things I like to point out, I think many people agree, is that molecular testing can be complex to interpret. Again, depending on when we have large comprehensive genomic profiles, other types of these reports, they can go on for pages and pages and pages. Even our disease-specific panels are about 10 pages long. I think the other thing then gets back to my idea of lack of cohesion. So this is a case where both send-out and in-house testing was performed on the patient. Those who were interpreting send-out testing didn't necessarily know about the in-house and vice versa when we signed out our report. And these test results, if you've ever tried to track them down in the medical record, are not well organized. They are difficult to find. There is no single dashboard that has all of the patient's molecular genetic information on it, whether that be germline or somatic. And it's very, very difficult, even if you are looking purposely for it, but if you are not looking purposely for it, to be aware of all of the testing that is performed, because it can be in different parts of the results review or the other parts of the medical record. And doing all of this integration is very time-consuming and complex. And it took me about an hour and a half of chart review before I felt comfortable proceeding with what these next steps were. So let me tell you a little bit first, though, again, about what I learned as I did a chart review on this patient. So she had presented about 1.5 years prior to this note. She was an early 50s female with postmenopausal bleeding, and she had an endometrial biopsy which showed a high-grade adenocarcinoma. Some of these words are taken directly from the path reports. There were features of serous that were noted, and napsin A was focally positive, suggesting perhaps clear cell differentiation. At the time that this biopsy had been taken, they did a staging CT before proceeding to operation, which of course is a standard clinical protocol. And they found that there was abnormal mediastinal right hilar lymph nodes, and there was no pulmonary mass identified. So they were a little bit uncertain of what to do. Just a little bit of eye candy for all of you anatomic pathologists to prove to you again that this was a morphologically heterogeneous and high-grade appearing endometrial biopsy. And so the next thing that they did after the endometrial biopsy was again to go after those mediastinal lymph nodes with EBUS cytology. Station 7 and Station 11 lymph nodes were positive for malignancy. It was consistent with carcinoma. But as you can see with my big exclamation point, There should have been a little bit of a pause here. It was negative for PAX8. It was negative for estrogen receptor. It's also negative for TTF1 and P40. And so basically that was all the material that was left in these cytology blocks in order to do it. And so after talking with the clinical team, despite knowing that this PAX8 was negative, they basically said there's not enough material for a definitive diagnosis. And this is from a clinical note. However, this appears unlikely to be a lung primary, again, given the TTF1 and P40 negativity. And so they decided to pursue neoadjuvant paclitaxel, as would be common with what was believed to be stage 4 endometrial carcinoma at that time. After 10 cycles of NACT, they did interval CT imaging. The primary uterine tumor completely disappeared, and we'll talk a little bit about why that is in a moment. And also that lymphadenopathy within the mediastinum disappeared as well. Actually, I shouldn't say disappeared, but it showed a remarkable response. And so they proceeded with a hysterectomy, BSL, and lymph node dissection. This is 8 months post-diagnosis after the NACT. And the pathology report on that showed that there was no gross pelvic or abdominal disease, from the operative report. And then the pathology showed that there's a complete pathologic response to the primary tumor. All the nodes were negative. And so this was a little bit odd. And so Gyn-Onc actually requested, and I didn't know this at the time, but they actually requested that we do a post hoc retrospective molecular classification or molecular characterization of the primary tumor. So a clinical order was put in, went back to that sample a year and a half prior, and we did our 3-gene classifier in the endometrial carcinoma. And again, the reason for this clinical request from Gyn-Onc was that they wanted to understand what the molecular subtype was in context of this clinical complete pathologic response. Part of that, again, is what the clear cell is known to be chemoresistant, and serous carcinoma can generally show a wide variety of responses to carbopaclitaxel, and so it didn't really make sense that there was such a exuberant response until, of course, we got our molecular information. So we found that, in fact, this was a POL-E mutant endometrial carcinoma, and this is a disease-defining driver mutation. The tumor mutation burden in this case was 112 mutations per megabase, which again is consistent with a POL-E ultramutator endometrial carcinoma. Now, part of the problems as we kind of think about the Swiss cheese model of why this error occurred is that when this was submitted, the molecular pathologist who signed the case out wasn't actually aware of the total clinical context or why this was being asked for retrospectively. As Mahmoud had hinted at previously, we do a lot of this testing in order to provide a diagnostic classification for endometrial carcinoma. So it was basically here, this is POL-E mutant endometrial carcinoma, let's put this out on the medical record. But really we should have paused to think at that point because again, for those of you that know Gyn-Path very well, POL-E mutant endometrial carcinomas do very, very well. So this is data from the TCGA study back in 2013, which defined the 4 molecular subtypes of endometrial primary carcinomas: POL-E ultramutated, MSI hypermutated, what is called copy number low in the original classification, which has become no specific molecular profile, and then copy number high, which is essentially serous-like and which has become defined in the PROMIS classifier and other ways to implement this in practice, is P53 mutant endometrial carcinoma. And as you can see, the POL-E mutant endometrial carcinomas over relatively long periods of follow-up do extraordinarily well. And this can be despite the fact that they can look quite ugly on morphology, and they can have high-risk clinical pathologic features that would have otherwise, by older GOG risk criteria, put them in a high-risk category. And yet those patients still do very, very well. So really there was kind of a lost opportunity at that point because it wasn't understood clinically why that retrospective testing had been requested. So after that, that report went out, the patient continued to be followed post-surgery with CT imaging, and 4 months out from the THBSO, the patient showed that there was new right hilar soft tissue thickening. That continued to progress over another 4 months, and so they were concerned for recurrence at the metastatic site, and an additional biopsy was acquired. This time, more definitive tissue was acquired, and that starts to tell you where this story goes. And so now this time the surgical pathologist made very clear to the Gyn-Oncs that this really didn't seem to be a pulmonary or Mullerian origin tumor. So they did positive IHC. You can see that CD117 comes up positive, as does CK7. You'll see a little bit on the next couple of slides with morphology what you might start to think in that context. And again, PAX8 remained negative. It very clearly in the diagnostic comment says that this is a nonspecific immunophenotype, but there's no clear evidence of pulmonary or Mullerian origin. Again, they don't go much further than that, and again, it's not necessarily clear in hindsight exactly how much communication or how much clarity there was with the clinical team. But they did recommend in the Surge Path report that molecular testing could be helpful to determine that site of origin. And so the clinical team requested outside molecular testing, again, leading to disintegration or discohesion in test results. It wasn't sent to us, it was sent outside to try and figure out what was going on. So the endobronchial lesion looks like this at low power, and if you get a high power view, you can start to see a little bit of some of the morphologic features which might be characteristic of this entity. There was a parallel lymph node cytology, what you can see here, and again, remember this is a CK7, CD117, or c-KIT positive lesion. So really we should have been thinking to ourselves, well, quite honestly, all along, once we actually knew that this was polymutant cancer, that it would be incredibly uncommon to be facing stage 4 polymutant endometrial carcinoma. Certainly the biology and the clinical course of this is highly atypical, and the morphology, now that we have a much better look at it in the subsequent biopsy, is not a good fit for it either. The hilar and the mediastinal disease never had a consistent differentiation profile suggestive of gyne origin, and so really that was, the best clinical overall guess at the time to label the patient as stage 4 endometrial carcinoma, but it was a little bit of an overreach. And again, remember that molecular, when I was consulted after all of this stuff had come together, after the outside test profile had come back together, was asked, explain why the pulmonary recurrence had lost the POLE mutation. So this is the front page from the outside testing results. Again, I've somewhat blinded where it's coming from, but some of you will probably recognize this type of a test report. The thing to notice with this type of a test report is the very first thing you see at the very top of about a 14, 15-page report is results with therapy associations. These are all negative in the current context, and they are all based on the presumption that this is metastatic advanced endometrial carcinoma. On the first page, there's an important note. I've left you a little teaser here. Can you read the small print? Right here. It says, by the way, I guess you guys can't actually see my pointer, so I apologize for that. Right there. In tiny print, a MIB NFIB fusion was detected by RNA sequencing. And oh, by the way, that's usually identified in adenoid cystic carcinoma. Again, as this audience knows, the MIB NFIB fusion is essentially a hallmark of adenoid cystic carcinoma, and most of you probably were guessing as I was making a big deal out of it with the CK7 and the c-KIT positivity, that again is another good immunoprofile for adenoid cystic carcinoma. While most of us in AP usually think about this as a salivary gland tumor or in the breast, bronchopulmonary primary adenoid cystic carcinoma does occur. It is rare, but it does occur. And so here are some of the problems that were evident to me at this point. So when we look at this type of outside testing, their interpretation is geared on automated therapy associations. And they gear those based on what the clinical team submits that as. And this clinical team submitted this biopsy as suspected metastatic endometrial carcinoma. And so the entire report is geared on that assumption. When that report came back into the medical record, the surgical pathologists are not immediately notified of this key finding of this MIB translocation. And again, if you had read a little bit more into the small print on that important note, it continues with other endometrial therapy associations and other trial options for endometrial carcinomas with the profile, the comprehensive genomic profile that came out of that test report. There was no urgency to work up a potential misdiagnosis at this point when this medical information came back into the record. Goes on a little bit more through a couple additional pages. By page 4, I also wanted to point out, as I was reviewing absolutely everything within this test report, that they also failed to discuss the fact that there's a BRIP1 mutation, which is a cancer predisposition gene within the homologous recombination repair pathway, that is at a variant of frequency right at 51%. And so there's a clinically relevant, likely germline finding that has absolutely no comment anywhere in this outside testing report. Clinicians had no idea about it. So after I'd gone through about an hour and a half of chart review to understand fully what was going on, I got back to the gyne-onc team with Epic Communication. She doesn't have metastatic endometrial carcinoma. Her tumor, her primary endometrial cancer, is long gone. You blasted it away with the NACT, and this is likely a rare primary bronchial adenoid cystic carcinoma. At this point in time, they had no idea. No one had ever talked about this in a multidisciplinary tumor conference. No one had ever gotten molecular pathology, surgical pathology, gyne-onc together to talk about what was going on in this patient. So I basically told her I'm bringing in the surgical pathologist because we were going to, talk about the diagnosis that was in the medical record from the AP side of things, as well as get in touch with the gyn-onc. I really like this gyn-onc nurse. You can tell by the fact that she first reacted to me as, "Hey there." And she said, "I hate," quote, again, blinding at those complicated outside test reports, just for the record, and thank you for reviewing this. Got in touch with our surgical pathologist. She said, "Yes, of course, this is exactly what's going on. We'll get things ensured that there's clear clinical communication and documentation so that the clinical teams now act on this appropriately as a primary bronchial adenoid cystic carcinoma." But then the nurse really kind of hits home with this message, which is, again, because there was a lack of clear and integrated communication between us as diagnosticians and the clinical team. The patient was already being treated with Keytruda as a POL-E ultra-mutated TMB high endometrial metastatic carcinoma for that recurrence within the chest. And this has no role whatsoever in the treatment of adenoid cystic carcinoma. And so I started trying to page and call that doctor, and then I also let the nurse know, and by the way, they almost certainly have a germline BRIP1 mutation. Again, not knowing anything about the family history, the patient's family context, whether they have offspring, sisters, brothers, whatever. We said we need to get them hooked up with germline genetic counseling as well. And I closed it. As you can see, I so hate disconnected care with send-out laboratories. So again, like I said, adenoid cystic carcinoma primary to the bronchial or pulmonary tree is extraordinarily rare. It's less than 0.2% of all primary lung tumors, but she fits right into the age range, 40 to 60 years of age. And like ACCs and other spots, MIB translocation is pathognomonic. But the only silver lining within this is that, again, the adjuvant chemotherapy regimens for ACC is carbopaclitaxel. So that does probably explain why, when she had an ACT for her presumed stage 4 endometrial carcinoma, she did have a reasonable response there. And then again, really what it comes down to is surgery is the only way to really treat and to cure these patients. If you've got good margins and a full surgery, they tend to do relatively well. If not, with positive margins, they don't. So subsequently, she was thought to be a good surgical candidate when she was hooked up with thoracic oncology, both surgical and medical. However, that initial surgery was aborted because there was diffuse disease not seen in imaging, and this probably explains why when she was imaged in the first place, they never understood that when they finally got her to surgery, there's a 6.2 centimeter primary tumor. Just was essentially not well documented, not well understood, not well found on the imaging. So again, the initial surgery was aborted, but after considerations in tumor board, they did think that they could go back in and do it. They thought that they had close margins, but they thought they had a pretty good surgery. However, there was lymph node positivity, there was perineal invasion. And so, 4 months out post-thoracic surgery, she had additional spinal cord metastases. She did opt for hospice at this point. Like I said there in the third bullet point, or fourth bullet point, genetic counseling was referred, again, based on the identification of that BRIP1 mutation on her somatic outside testing, but it was never realized because she passed away before that. So some closing thoughts, and again, I want to tie it back to a lot of the things that came up, I think, earlier in the morning session. So again, this is just a very, very, very rare tumor with a very clearly aggressive biology. But one of the things that I learned from this is, and really took away from it, is that disintegrated results across reports really led to a lost opportunity, a misdiagnosis up front. As I had mentioned, it never got integrated in a tumor board or a multidisciplinary conference where the right diverse set of practitioners were talking about all of these results in a single place. And I thought to myself, would local testing have caught this earlier? And my answer was perhaps, but actually perhaps not. And this is why. So Mahmoud had talked a little bit about our endometrial biomarker pathway testing that we do here. And again, like I hinted at it, the clinicians ordered that testing retrospectively on a biopsy because they were curious, but not because it was needed for diagnostic classification at that point. And right now, our pathway protocol is that we test the surgical specimen, and a lot of people from a lot of disciplines, whether it's GynPath, MolPath, or gynecologic oncologists, have put their heads together to design that in a thoughtful way. And again, that works for the vast majority of patients, and it puts the right diagnostic classification on our patients at what we believe to be the right diagnostic time. But we don't usually test biopsy samples in our system at mHealth Fairview right now. And like I said, there's good reasons for that. But then I kind of thought to myself, well, what if we had tested our biopsy at that point before we decided to go to the stage 4? Maybe this is an opportunity for improvement in the future. What if before we proceed, with labeling a patient as a stage 4 endometrial carcinoma, we go back and test that primary because, again, we didn't know that poly status until long after she had received her neoadjuvant chemotherapy because, again, that primary, that problem with that diagnostic pitfall, that misdiagnosis, was that first biopsy of the mediastinum was insufficient. Basically, a couple of immunostains were able to be done and nothing else could be done. It was very small. It was very tiny. It was very difficult to diagnose. And so the only other option would have been there is if we had tried to do ctDNA testing for that to characterize her disease in that quote-unquote metastatic or advanced stage and potentially found that mid-fusion. But the only thing that I really paused was if we had gone back and we had actually tested that endometrial biopsy up front and found that it was a POLE mutation, would that have caused us all as a team to get together and stop and pause to think, is this really what's going on, or does she have a second concurrent primary? So I think this has actually been a good meeting today to talk about this idea of an evolving role for pathologists. Tests provide data, we provide clinical care. We integrate our findings, as Pari nicely talked about. We have to be incredibly aware of the imaging and the clinical context before we look through a microscope and make a diagnosis. And when we integrate all of those things, whether it is different test results, whether it is clinical results, imaging with what we see under the microscope, and what we understand about disease biology, that's what drives best patient management. So this is what I always told the trainees when I presented this previously, which is be inquisitive, be critical, be integrated in your thinking, and demand things that make sense. Because along the way, there were a few times where people could have stopped and really thought, like, this just doesn't make sense. And so try and separate the signal from the noise, because occasionally, despite what Pari was talking about with the floater, you do see some zebras hanging out with the horses. So thank you very much, and we'll go on to the 9th inning. Thank you.
Thank you very much, Andy. We have still 2 minutes before our next speaker for a quick question. Dali?
So, Andy, I'm going to ask you a question I asked you 3 years ago, and I think I renewed the question last year, so it's time to renew the question. What's the advantage to sending cases to carries, and are we likely to catch up to make that unnecessary in-house?
Great timing, sir. 2 days from now, we change our underlying backbone from 127 gene assay to a 500 plus gene assay that again offers everything: copy number, MSI, TMB. As you already know, we already offer TMB in all of our disease-specific panels. Time will tell to see if we can turn the tide. There are certain biomarkers and things that are always a little bit difficult to keep up with the Joneses, and some of those things actually, personally, I don't think are that clinically relevant. But as of Wednesday this week, you will be able to order Minnesota Cancer 500, which is essentially a biosimilar test to anything that you can get on the send-out market right now. Yeah. To a degree, and I think the other degree, and there are people in this room that need to be called out. Brooke, you're in here. Carla, you're in here. Michelle's in here. There might be others that are in here that I'm missing. But a lot of it is also the informatics. A lot of it is the fact that we are working very hard in the biomarker care map to understand and to develop ways that we can get discrete molecular information into a discrete tab or a discrete dashboard, where regardless of whether it comes from, and obviously it's a lot easier if we generate it all in-house, but regardless where that information comes from, that you can see in one place quickly and easily what are all of the molecular oncology characterizations, what is the imaging, what are the path reports. There is a cancer staging tab right now that I'm desperately trying to get all of our oncologists to use, but it actually does a scrape and it pulls in relevant radiology reports, path reports, molecular reports around a date of diagnosis for a malignancy. And that, again, it's another opportunity where we can actually use the electronic medical record to our power rather than just letting it be a billing and clinic scheduling tool to organize this information and put it in a digestible way for our clinicians so things don't get dropped. Cool. Thank you, sir.
Thank you. Thank you.